All right, so if we have some choices, all right, let's say we want to say that Patty is a 24-month-old with stridor. Okay? Is that an objective statement? Is it a subjective statement? Or is it a clinical assessment? Or is it a diagnosis? This one's a little tricky, okay? Because to us, right, okay, in your mind, when you hear stridor, that tells you that it's an upper airway obstruction, all right? It doesn't tell you from what. Right? But if somebody tells you stridor, that sends little signals in your head, and what are you going to want to do? All right, treat the upper airway edema with a racemic, or epinephrine. I say racemic because I'm old, okay, but with an epineb, all right, to target that edema, okay? But what else do you want to know about that patient? Is them having stridor enough? Does it really tell you what that patient's physiologic status is? If all I say is the patient has stridor, does it tell you their degree of respiratory distress? No. Does it tell you if they're adequately exchanging, if they have adequate air exchange or not? Does it tell you if they're hypoxic or not? Okay? All right? So it's an objective statement, all right? But the reason it's a little confusing, and the reason I always do this one, is because there's a couple of those buzzwords that, we hear, all right, that we think we know the whole story, but we don't really. So, what the clinical assessment statement would be is that Patty is a 24-month-old with increased, say moderate increased work of breathing, fair air exchange, all right, with stridor, all right? Now you have the whole picture, all right? You know what her current physiologic status is, how are you assessing her respiratory distress, and you throw in that stridor, and now it helps you understand why, all right? So now, when you give that epinephrine neb, all right, and you reassess her, what if your reassessment is, post epinephrine neb, there are, she has no retractions and good air exchange, okay? All right? Does that make sense? Okay. All right, but I throw that one in on purpose because there are certain buzzwords that we all want to react to. All right, it's just the other one that's like that is DKA. All right, it's something that even most practitioners that aren't MDs, all right, feel very comfortable making that diagnosis, even though they're not a physician, okay, because it's something that we see frequently. It's a certain set of symptoms and lab findings that we have, and so most people feel fairly comfortable saying this patient's in DKA. With if you take one step back, what you should really be saying is that the patient is having, if it's appropriate, signs of severe dehydration with hyperglycemia and a metabolic acidosis, right, with moderate effort to compensate, for respiratory compensation. Okay, that's DKA. But again, it has to do with how comfortable we are with that set of symptoms and interpretation of them. All right. So, I mean, what we end up usually saying is something like, the kid, over in room 10 has signs and symptoms that are consistent with severe dehydration, okay? That would be okay. What makes it better is, if you throw in things, tell me what those signs and symptoms are. They're tachycardic, decreased peripheral perfusion, and no urine output, for 4 hours, all right? And there, which therefore is, whatever, all right? If you give me just enough information to let somebody know that your clinical assessment, you're backing up your clinical assessment, okay? But that's the whole idea, is that you succinctly, in one nice phrase, are able to communicate that patient's current physiologic status with other medical personnel, and then it guides your response to that, and it guides your treatment plan, okay? All right, that's it.